Hello, my name is Dr. Rina. I am currently a family medicine doctor at UCSD and also the medical director of the California Smokers Helpline. Thank you for joining us today for this brief overview of helpline services and e-referral options for healthcare providers. I will be presenting along with Dr. Cathy McDonald, a consultant at the Alcohol, Tobacco, and Other Drugs Provider Network, and would also like to thank our partners Neha Gupta, a physician at the Alameda Health Systems, and Ryan Hensler, EMR Manager, Lifelong Community Health Centers. I would also like to thank our funders, the CDPH and also First 5 California. Our agenda for today is I will be reviewing the California Smokers Helpline services, materials, and options for e-referral to the helpline. And Dr. McDonald will be reviewing best practices, examples, and getting started. For PDF copy of the slides, please email kharms@ucsd.edu. I'd like to go over the helpline services. The California Smokers Helpline, also known as 1-800-NO-BUTTS, is a free statewide quit smoking program established in 1992 by UCSD researchers. It's funded by tobacco taxes, has been validated in randomized controlled trials, and is available to all California residents. We also provide services in multiple languages, including English, Spanish, Mandarin, Cantonese, Korean, and Vietnamese. We are open Monday through Friday, 7 a.m. to 9 p.m., and Saturday, 9 a.m. to 5 p.m. We provide free client services, telephone counseling, up to 5 one-on-one sessions with a trained counselor on smoking cessation. There's also special counseling protocols for pregnant smokers, teens, and tobacco chewers. Free nicotine patches are available for qualified smokers who are either pregnant or have children aged 0 to 5 in the household, or if they speak specific Asian languages. This is made possible by funding from First 5 California and the Centers for Disease Control. In most cases, Medi-Cal members can get NRT, which is nicotine replacement therapy, from their pharmacy with a prescription. We also provide text messaging programs and also online chat on our website at www.nobutts.org. We also have mobile apps that are available both with the iOS system and Android. In addition, we also have online help via our website, see link in PowerPoint presentation, and also have self-help materials that you can download and print for free. And we also have a referral to local cessation programs. On our website, you can see the county listings of places that are available. Of the free helpline materials, we have multiple options of free materials for tobacco users, friends, and family, and also for healthcare professionals. This includes fact sheets, rack cards, and wallet cards that you can get from our website at www.nobutt-catalog.org. We also have helpline materials in different Asian languages at the Asian Smokers Quitline website, which also include rack cards, brochures, wallet cards, and posters. In addition, we have options from the Tobacco Education Clearinghouse of brochures and wallets that you can download from their website at www.tecc.org. I'd like to now go over the helpline proactive referrals. So an e-referral to the helpline is a very effective method for increasing tobacco interventions in community clinics because it is built into the workflow in the electronic medical record and often spreads the work over multiple providers. So having an e-referral to the helpline helps to increase reach, access, and cessation of tobacco use. This can help FQHCs achieve and document quality standards such as MIPS and meaningful use, and also can increase tobacco counseling interventions measured by UDS as required by HRSA. The benefits of a helpline e-referral is that you can have more tobacco interventions that occur, and hopefully that will be documented in the EMR. As multiple staff are involved, it can help to reduce provider burden. Also, patients will get the message from FQHC staff that they want them to quit smoking or use tobacco products. It also puts tobacco intervention on the front burner, especially for high-risk populations with high tobacco use rates, served by community clinics. It also can be incorporated into interventions for behavioral health patients who have the highest rates of tobacco use, and is also consistent with AAFP recommended tobacco practice. A proactive referral is when a provider sends a referral to the helpline via a web-based direct or peer-to-peer referral. This referral then gets sent to the helpline, and someone from the helpline will call the client within 24 to 48 hours typically of receiving the referral, and 5 attempts are made to try to contact the client. We have found through multiple studies that proactive referrals can help increase services to patients. In the study where pregnant patients were told by providers to call the helpline themselves, only 2 to 3% of those patients in fact called the helpline, whereas through a proactive referral, 40% of patients agreed to service either counseling or receiving materials from the helpline. Of the e-referral options, one of the possibilities is a one-way direct messaging, which is free to the provider except for the cost of direct messaging accounts. Most organizations already have a direct messaging account. Referrals can be sent from the electronic health record or via a separate portal. This can be eligible for meaningful use. A summary of the referral report is available upon request. An additional setup and monthly charge will apply for a bidirectional interface, which is when the helpline receives a referral from a provider, and then the provider will then receive information about the client that was referred, whether they were contacted successfully, whether they started counseling, or whether they were in fact able to get nicotine replacement therapy. Another option is peer-to-peer referral. This referral is sent from the electronic health record and may also be eligible for meaningful use. Individual level data is sent back to the provider. There is, however, significant additional charges for setup and monthly maintenance. And now I would like to introduce Dr. McDonald to discuss best practices for helpline e-referral.
Thank you so much, Dr. Eddy. I am really excited to be able to share about the e-referral and the different ways that it can be done through direct messaging. So the best practices are for the agency to really look at how they want to set this up, identify a tobacco champion to work with a team of staff authorized by the clinic leadership, decide which of these staff will be making the referrals. Is it going to be the MA, a nurse, the providers? Determine how the e-referral will be integrated into the clinical workflow, and this is really important. The more clearly it is integrated, the more successful it will be. Develop a simple organizational policy that authorizes medical assistants or other non-providers to make the referrals, because that can be an unusual practice rather than having the provider make the referral. So you would like it in the policy. Coordinate with the IT EHR staff on where the helpline referral will be placed in the EHR and what it will look like. So an agency has to work with the EHR staff to modify the system so that the clinic staff can easily select tobacco cessation counseling as done. This is in the case of when the system is modified by the EHR staff, which isn't essential. We'll look at that in a minute. So they will have an opportunity to select tobacco cessation counseling done, select referral to the helpline, pull key data from the client's chart, including name, sex, and language, and either pull the phone number or allow the staff to select the ideal phone number from the ones that are already entered in the chart. The best practice can include a bidirectional referral, and in that case, you would want to determine how patient feedback would be sent. Would it be sent to the individual provider, or is it going to be sent to one staff person who would get all of the feedback and dole it out to people, putting less burden on the provider's mailboxes? In addition, it's helpful to provide each patient who is referred with a helpline wallet card, which may be ordered at the website shown here. It was mentioned that you can request data, and this is an example of the data where almost 1,700 referrals were made, and 44% of those patients were reached when they were called back. 40% were not able to be reached, and 15% were still in the attempting phase. If we look at the ones who were reached, you can see here that a whole 70% of them actually chose counseling, and 13% chose materials, and only 17% refused the service, even though they had previously agreed to it. So that is very useful data for clinics to be able to see how their system is working. Let's look at some specific e-referral examples. All these examples are from NextGen Share direct messaging, and similar systems exist for other EHRs. In this example, if you have NextGen Share turned on, you would follow the same system with the orange box that you always do, and in this case, you would search, instead of for Dr. X cardiologist, you would be searching for California SMO. California S may be sufficient, and then on the right-hand side, you'll see choices, and the California S is going to bring up the California Smokers Helpline. It's helpful for meaningful use to be sure that you also have in your list of possible referrals specialty addiction medicine. So that's the easiest, well, let's say it's the most straightforward way without any customization to refer through the direct messaging. Now we're going to look at two alternatives that did involve customization. The first is Alameda Health Systems on the direction of Dr. Neha Gupta. They developed a system which included training of all their medical assistants, and they had the medical assistants doing all the referrals. They generated large numbers of referrals because it was automatically included in the MA's workflow, and it did include the provision of the Helpline Wallet card. You can see here that the MA did their usual activities, going to the screening summary link, and then for tobacco, they chose whether the person was a current, former, never, or unknown smoker. And then if the person was someone who smoked, they would complete tobacco usage. That was all part of their normal workflow. If the patient was not a current smoker, they're done. And if they were a current smoker, they would go on to this additional part of the workflow, which you can see is very simple. They would offer tobacco counseling and referral to 1-800-NO-BUTS and offer a card. They would check that they had completed a tobacco cessation and intervention in the first red box, and then they would click yes that tobacco cessation had been completed in this encounter in the second red box. Then they would ask the patient if it was okay for them to refer to 1-800-NO-BUTS after giving them information about it. And if the patient said yes, they would click on yes in this first box, and if they said no, they would click on no. If they clicked yes because the patient agreed, then they would automatically see referral to 1-800-NO-BUTS submitted, and that would complete the referral. Now I'm going to discuss with you or just present a different option from Lifelong Community Health Centers, which is an alternative way of doing this. It shows another way of sending the referral and documenting the consent. Alameda Health Systems example has a much simpler language piece about the consent in it, which I think is easier for medical assistants to follow. At Lifelong, it could be the provider or the medical assistant who did it. The medical assistants were encouraged to check off counseling less than 3 minutes because they are talking to the patient about the helpline. Providers might check a longer period of counseling. And automatically, instead of going through a 5-click process, this would automatically click off that the person has received a tobacco cessation intervention. Then the staff would check the California Smokers Helpline if they wanted a referral, check that that was a patient, check that they had consented to this more cumbersome language, and then select the phone number that the patient said was the best one for the helpline to reach them on. After doing that, they would click on Send California Smokers Helpline, and the red letters e-referral sent would automatically show up at that point. If they wanted to double check, they could go to the referral manager. So are you ready to get started? If so, we really encourage you to register for direct referral to the helpline and find out more about peer-to-peer referral if that's what you're interested in. And we urge you to contact Carrie Kirby at the California Smokers Helpline for more information at this email address, ckirby@ucsd.edu. Thank you so much for allowing us to share this wonderful method for helping more of your clients to be able to stop using tobacco.
We are excited about using the power of video to promote California's community health centers. Share your mission, your team, and the community you serve through the use of visual storytelling. Nonprofits frequently leverage video to communicate with their supporters and the public. They share who they are, spread awareness, and inspire action. They tell the story of their impact. They use video to motivate their fundraisers, celebrate wins, build community, and personalize their mission. So, what can you do? Participate in CPCA's 2019 video contest, Beyond These Walls. Submit a video to show how your health center has effectively created impact, access, innovation, or value for your patients. This is your chance to win the first place prize, $5,000 in marketing services by Uptown Studios, or the second place prize, free registration to all 5 of our conferences in 2020, or the third place prize, a GoPro equipment package. Beginning in January, you can upload your video to our website and get your team and community to vote every day for a chance to win.